Here are our objectives for the next 35 minutes or so. With teaching at the bedside, we certainly want to understand the environment, appreciate the goals for each individual, and learn specific strategies to execute and improve. All right, so earlier we had a team that you were about to begin working with as the attending that had third-year resident and intern, 2 fourth-year students, 2 third-year students, and a census of about 14. It's basically a general medicine inpatient service that's being described. And you have 2 hours to round each day, and you know what your priorities are. And really the thought is, what are some ways that you could enhance the efficiency and the quality with which you do this? So I'm actually curious, for any of you in the room whether you've been an attending or not, I'm sure you've been in a scenario similar to this. What have you seen, and don't think about bedside teaching right now, but what have you seen others do or that you have done that has helped enhance the efficiency and quality with which you do this, with which you manage the service? Right, so don't try to teach it all. You'll wind up teaching nothing if you try to teach it all. What have you seen someone do that has helped enhance the efficiency and the quality of the care and the whole experience? How about this? What have you seen done poorly? Yeah, and those can be really time consuming. I mean, if you have ever been with a family member in the hospital for a long time, or you yourself have been in the hospital for a long time, it is psychologically traumatizing. And you are usually wanting to talk to somebody. You could wind up consuming 15 or 20 minutes of the 2 hours you might have to round talking to somebody who really doesn't need much in the way of medical care, and there's not really anything left to teach. It can really hurt your efficiency quite a bit. All right, so obviously we're going to talk about one way that I strongly believe enhances your efficiency and the quality of care you deliver, and that's rounding at the bedside. So it all begins with understanding the environment, and this looks familiar. Where are you to begin with? So we are going to talk a little bit about clinic, because clinic actually is an opportunity to round at the exam table or see the patient at the exam table together. So we are going to discuss that. Most of this is going to seem much more applicable to the hospital environment, and really I think that's probably the place where you really get the most bang for your time too, as well, that you have in front of the patient is also. And again, you saw this earlier too, it's really all about your time, and that's why probably it's not the number one reason, but it's right up there at the top about why bedside rounding is so effective. You are making the maximal use of everyone's time. The patient's time, your time, the learner's time, the time of day that you have. How many times have you been on rounds where you had a discussion outside the room, then you went inside the room, you had the same discussion, and then you came back later in the day, you had the same discussion again, and it just, eventually that gets tiresome, right? So doing it once and not having to repeat it again. It's also important to know when you're thinking about your rounding is who is going to be there, how many days are you going to have together, because you need to think about, and Ashraf touched on that a little bit, and to know how to kind of spread the wealth over those days, and also know who's not going to be there on certain days so that you don't accidentally spread the wrong wealth on the day that the learner who needs to hear it the most is not there to hear it. So it's very important to know who's going to be there with you as well. It's also about your audience. So that's not just the learners, it's not just the patients, but think about this. If you are standing in the hallway at the hospital, think about everybody who is now the audience to your rounding. Well, some of this is fine. You actually want the nurses to be part of the audience. That would actually be very nice if the nurse is there with you while you're talking to the patient. And sometimes it's great if you walk into the patient's room while physical therapy is actually happening, and you get to see the patient out of the bed and try to walk on their own for the first time and talk to the therapist about what they're able to do. It helps you figure out what needs to happen at discharge. But if you're out in the hallway, the cleaning staff, your patients, family members that they might not want to know anything about what's going on, their friends, other people's family members, other patients. Of course, I have seen the instance of the other patient being in the room with the patient before. You might have encountered that too. But out in the hallway, there is much more opportunity for everybody else to hear what's going on about this patient, because you're just in a much more public place. Now, That's not an exhaustive list of everything about the environment, but there is something about when you step in the room and you're there and the patient's there in the bed and you walk in and you see who all is in the room, you do have the opportunity there to say, tell me who everybody is. And then if you can ask the patient, do you want everyone to be in the room as we talk about you? Because we are going to be talking about you out loud. And they have the opportunity to say, no, I would like for them to leave, or you can ask certain people to leave. Out in the hallway, you don't have that opportunity. They're just going to be present. And they can walk up, as you've probably also seen, people can walk up to you and just start asking you questions about the patient in the room, and you're really not sure who that is that's asking you questions. So definitely, as you walk in the room, more control. So there are certainly other factors too as well about the environment, but those are definitely the important ones that you want to grasp as you begin rounds. So before we go a little bit farther, I definitely want to take just a step back. Well, actually, we'll probably cover it right in this area about appreciating the goals for each individual involved. If we don't cover it all, I'm going to say a word or two about expectations in just a minute. All right, so you definitely want to know what everybody's goals are. This is the patient's goal. As you probably know, most of the patients are in the hospital. The problem, and I'm going to actually reference Dr. Weiss again here, is to get the oxygen from out here to here, right, to the brain and to the heart. Something has gone wrong, typically with that's gotten them into the hospital. Sure, there's other, at times, issues like a soft tissue infection that didn't really affect the patient's ability to oxygenate, but ultimately the patient wants to keep breathing. Whatever problem it was got them worried enough to come to the emergency room, and they thought that it was threatening enough that if they didn't go to the emergency room, their life could be in jeopardy or something serious could have gone wrong. So they also want to be treated with respect in that entire process. What about the medical students? Well, this, I hope, is not their only goal. I think that most of the students would find this very nice if they got an A+. If your school gives out A's, B's, C's, and so on. But I don't think that that's all that the students are actually seeking. I think they actually have some other goals, and some of them they would not want to acknowledge very readily, but the first one, they really don't want to be embarrassed. And that's actually an issue with bedside rounding, and something that I think where bedside rounding really helps them overcome this constant almost self-awareness or fear about being wrong, is that by being at the bedside, by having to talk about the patient, in front of the team, and whoever else is okay to be in the room, they kind of get over this about being embarrassed and being right and get more comfortable with doing what it is they're going to be doing for the rest of their careers in front of everybody else. But really, when it comes to their development as a physician, what they're wanting to do is get comfortable with the exam. And I think this has actually become more and more important as the years have gone on, and we've been able to do more and more without necessarily doing the physical exam, or at least find out more information. But we can save a ton of money a lot of times for our patients by doing a good physical exam. And I think the medical students know, just like we all know, that there is something about the bond between the patient and the physician where touching the patient, doing the exam, just develops that trust that we want to have with our patients. So they want to get comfortable with doing the exam and feel confident that as they do it, they know, like, well, here's how you feel to see where their liver edge is, or here's how you know to feel the spleen, or here's what an S3 actually sounds like. So if they happen to mention these things on rounds, just to back up just a second to your attending role, make sure you go and you verify those things that they mention up or they bring up, and then say, yes, I heard an S3 as well. And that's a huge advantage when it comes to bedside rounding. You can do that right there in the room, right in front of them, even right in the middle of their presentation. They also want to know what's really important. That's the big progression really from going from that into history and physical that you take in the introduction to clinical medicine course or whatever your institution calls it, where you just ask the patient every single question in the book and you spend an hour and a half or 2 hours. The student is making the progression from there to where the upper level resident might be, where they can go in and in the span of 6 or 7 or 8 minutes, depending on how complex the patient is, maybe a little bit longer than that, figure out what's really going on with this patient. They're just amazed at how quickly the upper level resident or the attending can get to the heart of the matter, and that's a big goal for them. And then, of course, they want to learn how to make decisions, and a lot of that Dr. Henson just got through talking about, but bedside rounds are important for that, and we'll come to that. So what about the interns and the residents? Well, again, they're probably not going to come out and tell you, straight up, this is what their goals are, but certainly, and this is, it makes total sense. You got to this point by being right. So you don't want to be wrong. It's very ego dystonic for a doctor to be wrong. It really bothers them. So they don't want to make a mistake. And so I think also this getting in front of everybody and doing it all in front of everybody gets everyone more comfortable with, you're going to make some mistakes, but you can also get some immediate feedback about them right here. And you're going to be wrong sometimes, but you get immediate feedback about it right here. I think all interns and residents want to become efficient, and they understand that if I'm going to be prepared for practice when I walk out of the door on my own, I'm going to have to develop some efficiency. And also, we know this, that when you watch your residents or your learners and the ones who are efficient or appear efficient, they just seem to be evaluated better because they're getting things done. They want to find out where they're good and what they enjoy and what they don't like, but really, I really believe that interns and residents, just like I think any good conscientious physician wants to deliver excellent patient care. That is absolutely the most rewarding thing about being a doctor, is when you know you've given the patient good care, and the patient, to go a step beyond, tells you that they're really happy with the care that they got, or they want to come back and see you if it's in clinic again. That's very satisfying. So also, competency is, and we mentioned this earlier too, developing competency in each of these areas is very important. So when the ACGME came up with this language, I don't think it was to create some system that was going to require paperwork or was going to make it difficult, but just because they wanted a bunch of data points. I really do believe that developing competency in each of these areas actually does give you someone who is ready for independent practice. And I think it's important that you, if you're the attending physician, have to think about your own competency. Where do you excel among those 6 areas? Where is it that you need the work? I mean, I'll tell you right now, the place that I'm most uncomfortable is when we have a patient with complex renal disease. I mean, I know that that's an area I need to work. My medical knowledge, when it comes to the kidneys, it needs some work. And I can think about other areas. My communication, at times, and I've gotten some good feedback from residents before about this, that they needed some affirmation. They needed me to say, I agree with your plan because, and that my communication was lacking. So think about your own, and you need to review your past performances and set some personal goals. And that's something that's very easy to let slip by in the day-to-day busyness that we have, and especially if you have to deal with crises at work on a routine basis. Sometimes it's hard to sit and reflect. But I do think it's really important for your continued development to think of your own competency as an attending. And then determine what specific feedback you'd like to hear. So in the end, so that should be a goal of yours as an attending. I think a goal of everyone who's going to go on around. So now really, here's the real meat of this. So learn specific strategies to execute and improve. So how do I actually go about doing some bedside rounding? Where does it actually begin? First, it begins by knowing yourself. So if you are the attending physician and you decide we're going to do bedside rounds, you really need to know your own tendencies before you walk in the room, because if you're not totally prepared for that, something's going to happen in the room and you're going to default back to what feels normal for you. So if your normal tendency is to jump in and this is just to go back to a little bit what Dr. Henson was saying, to jump in, and especially if it's in a given area where you feel like you really excel and give the plan, you need to prepare yourself not to do that when you go in and do bedside rounding, because that's not the ideal thing to do outside of the room, but in the room it can actually undermine everyone else on the team and devalue them a little bit in the eyes of the patient. So you also need to know, how do you react? Or you tend to be pretty flat or stoic, or do you tend to express yourself quite a bit? Your facial expressions change in response to certain things that certain people say. What triggers you to perhaps be unprofessional at times? And we all have been that way at different points in time. Perhaps the patient who doesn't comply with any therapy, or the patient who asks for pain medicine well before the time is actually due. Does that spark you or make you angry or upset you? You need to be really aware of that before you walk into the patient's room. And then what are your strengths? And know those, and know that way you can pass them on. If you're really good at discussing end-of-life decisions, those critical times you're a good person who listens and who responds and the patient feels comfortable with, you want to role model that. You want to make sure that you have the opportunities to do that while you're at the bedside. And then let your learners teach you in those areas you're weak. So I've certainly had residents who taught me quite a lot about the kidneys where I felt weak. So I'll tell you this too, if you have a mixed inpatient outpatient practice and you have a resident who is very up to date on the literature and like say they know they want to go into hospital medicine and that person happens to be the upper level resident on the team, tell that resident at the start, look, feel free to teach on attending rounds because you might wind up learning a lot of up-to-date medicine that you could go on and then use the next time you're attending. The next thing, and this is really important, and if you've ever listened to somebody sign out or somebody present, and especially if it tends to go a little bit longer than you would like, or you've got a lot of other things that were going on before round started, so it is so important to be an active listener in the room because the patient is definitely listening if they're awake and alert and oriented. They are typically listening. Now, sometimes they might get totally lost in the details, but it will surprise you how many patients can completely understand what's going on, and they'll ask you a question because they can tell that the resident or student is presenting to you. And so they're going to turn and they might ask you instead of the resident or the student. So you have to be listening, and a good place to practice this is if you're married, practice with your spouse, practice with your children. The dog is not a good animal to practice with. It's not going to talk to you. And that's not going to transfer over to the hospital, but definitely practice this. And I do think this is important. Ignore your phone. The phone, it is one thing that I tell our teams at the start is that I will only respond to my phone if I know that it's an emergency for my family. But of course, if I'm totally ignoring it, I don't even know that that's happening. But your family probably knows how to get in touch with you anyway, even if they happen not to be able to get you by the phone. And nothing is more important than what you're doing right there. I can think of many times where I missed out on great teaching opportunities because I got distracted by a text message that could certainly have waited till much later. So you're going to want your learners to ignore their phone. You have to role model that as well. And certainly the patient, that will definitely bother the patient. You want to be very intentional. So one of the hardest parts about bedside rounding is there's so many variables and so many situations that can come up that it's almost impossible to deliver expectations on the front end about every single scenario that can possibly come up. But at the start, and we talked about this a lot at the beginning, but set out a curriculum and tell the team at the start, this was said just a little while ago about we're not going to see every patient every day. And if that's the case, and I do believe that it should be the case, you need to tell the team what the priorities are going to be. So one mnemonic that's used a lot, used in Dr. Weiss's book, is dire diagnostic discharge, DDD. And if your hospital puts a lot of pressure for discharges, sometimes the discharges have already happened before rounds have started. So then you're really thinking about the patients who are in dire need of your help and the ones who need a diagnostic procedure to advance the care of the patient or move them along in their hospital stay. So lay out some expectations about who we're going to see and empower the residents to make the decision if you come to the door about are we going to walk in the room and do this at the bedside or do we actually need to stand out here for whatever reason? Or is there somebody in the room that we need to ask to leave as soon as we walk in the room? And the residents, and the students have typically, or the fellows and the residents have already seen that patient earlier in the day and can tell you that before you walk in. You also want to think about, and this was mentioned earlier too when we were interacting earlier, is think about who has been making a lot of the decisions and then who should make the next decision. And that doesn't have to be the person presenting. That could be somebody else. And we're going to talk about where you should stand at the bedside on bedside rounds in just a minute. But at a place where you can see everybody really helps, and you can actually pick out who do I need to make sure is engaged, who needs to be asked the next question about this particular topic. Which patient are we going to spend a little longer in the room today because they really need us or because this is a great topic to teach on? All right, so being with the patient. So we're going to start talking a little bit about clinic. So typically in clinic, learner will sign out to you, and then you might go in the room together, which I strongly encourage doing. Sometimes even for, I think to me, all the way through training, it's a good idea to go in. And it's certainly a different visit when you're working with a brand new intern than it is with an advanced upper level resident. But even as the attending, you want to get on the patient's eye level. So if the patient is sitting on the exam table, they're already here. There's really no reason to sit down. You can just stand up. You're on eye level. You're talking eye to eye. If the patient's sitting down in the chair near the exam table, go find the other chair if it's available in the room to sit on. One way to get down a little bit closer if there's not a chair is for yourself to sit on the exam table and kind of lean into the conversation, but definitely engage, but never get between the patient and the learner. And so in my case, the resident. Precept a lot of resident clinic. I try never to stand between the patient and the resident, because as soon as you do that, you are now the doctor, and the resident is not the doctor. The resident is a student or somebody who's just came in to gather the information. And really for the resident, that's not good for developing their own comfort and their confidence, but certainly for their relationship with the patient, it's not good. So usually going over some information so the patient is aware that you know, just say, hi, I'm Dr. Thigpen. Dr. Buchanan told me that you're having some trouble with your knee, but otherwise you've been feeling pretty well. And right there, that can be it. You can stop right there, let the resident take over. And sometimes before you walk in the room, you can turn and ask the resident, how much did y'all talk about before, about the plan or about everything else? So you know at what point do you just turn it over to the resident. So always though, when the patient, and this usually happens when you go in the clinic room, the patient will ask a question, and sometimes they'll ask it of you. And so as soon as that question, you can almost think of it as like a volley. Question comes to me, and I just look right at the resident so that the resident knows it's time to talk and answer the question. But then remember too, if the answer is going to potentially jeopardize the patient or maybe give a medicine that's not appropriate or something, then that's the time to step in. But otherwise, just let it go. Just let the conversation flow. And it's a great time to evaluate the skills that your resident has with developing rapport with the patients. So new complaints will often come up when you go back in the room. The plan, of course, will come up and you'll go over it. The logistics of the plan, like where do I go to get the labs drawn or that x-ray done? And then other questions that might just come up randomly. So you always want to just try to defer those, let the resident or the learner answer those, the resident or the fellow. And then any differences of opinion, it's fine to go ahead and talk it out right there in front of the patient. I think one thing that does is it allows the patient to hear that, hey, they're actually giving some thought to this. So differences of opinion, again, being ones that are actually of consequence. As Dr. Henson was just talking about, it doesn't have to be your way. If it's an acceptable way, certainly let that go and let the resident develop their style. And then, like I said, correct only when it's necessary to do so. If you have a pre-existing relationship with the patient, I do think it's important to recognize that they might need to hear from you a little bit more. And that will actually help them grow their confidence in the resident, particularly if you're reiterating things and just really enforcing what the resident has already said. It grows their confidence in the resident's ability. Now in the hospital, it's a little bit different. The patient is typically in the bed, and I think that it's very important where you stand in the room. And there's a lot of symbolism here, there's a lot of strategy here, there's a lot of this really helps you evaluate everybody to come in and try to, and I'm a bit obsessive about this, I'll even move IV poles and other things out of the way, get on the patient's right side, up by the head of the bed. So you're close to the patient, and they can feel that, not like on top of the patient, but you're close to the patient. And then you've got to look out at the room. Everybody else is going to kind of naturally flow into the room and circle the bed. The ideal would be that the presenter is directly across from you on the other side of the bed from the patient. That's the perfect scenario. But if they are right here to your right, it's okay, but it's a little bit harder. And so you can lay out the expectation at the start that, hey, when we go in the room, wherever I am, if you would get kind of right in my line of sight. You don't have to say that I'm always going to get on the right side of the bed at the head, but you can aim to do that. And now every communication is coming right across the patient. The patient is in the middle of the line of communication, is in the middle of the conversation. And you're looking at everybody. So you can tell if somebody is not paying a bit of attention, and that's usually the next person to get a question. And I know that can be in some ways make somebody feel uncomfortable, but it only has to happen once. As soon as that happens the first time, you probably won't have that problem come up again, because everybody will realize, oh, I better be paying attention because I might get a question. And then it's okay to ask the patient or confirm with things that the resident might be saying or the student might be saying, but you can do the exam too right there. Just lean over with your right hand, do parts of the exam, feel for edema, do the abdominal exam, maybe save auscultation for after the presentation is over. But notice the eye contact too. From that perspective, you can see who is the patient looking at. If the patient is looking at the presenter, that usually tells you something about the rapport that's already been established there. And you will know very quickly, did they see each other this morning? And have they been seeing each other every morning for a while? It's very easy to pick up on that when you're standing from that perspective. And then you always want to make sure the patient knows who everybody is. There's tons of people that go in and out of the room. We are the primary team. And it shows a lot of respect to everybody on the team if you introduce them by name to the patient that first day. And then, of course, you want to review the plan in the patient's terms in case they didn't understand any of it. Ask the patient. So tell us, in your understanding, what you think the plan is, or something to that effect. So if there's not a commitment, you always want to defer to the learner. So if the presenter is not committed, you don't have to ask the presenter to make the commitment. You could ask somebody else, well, what do you think? And if you have gotten a good feel for how confident everybody is once you're 5 or 6 days in, so I'll give you an example. Last September, I worked with an upper level resident, and he was on top of everything. Like it took one day to figure out he's not going to get any more questions for about 6 days because he knows everything. And so the next 4 or 5 days, it was the intern who got to make a lot of the decisions. And then the intern would make the decision right there in front of the patient, and then just turn to the upper level and say, how do you feel about that? And then a lot of times he would affirm, or the student might. And that's something you'd have to deliver on the front end, is say, look, I might ask a question, or there might be a situation that comes up that you haven't had the opportunity to discuss. And if I ask you, what do you think? It's okay to say what you think, make a commitment. We can talk it out right there if there's a difference of opinion. Usually leaving the upper level resident to make the final decision. So definitely that last point, underscore without undermining, is very important too. When you do, if there are differences of opinion, or you want the team to think about the care in a different way than what they're proposing because you know that there might be some harm involved, to take a step back and say, all right, let's look at it just a little bit differently, instead of saying, no, we don't need to do that. Because as soon as you say that, it changes the whole tone, and it changes the way the patient looks at everybody else who's coming into the room. And you will wind up being the person who then gets called a lot about what are we going to do with the patient. And especially if you're the attending who's not writing orders, this can become really difficult to manage during the day. You're going to become the conduit for everything. All right, and then just a few words of caution, some of which I've already touched on. Just understanding the family environment is really important. So sometimes the family environment is very helpful. So if the patient is having trouble making decisions on their own, just because the mental capacity is not there, or they really have already expressed to you, I really trust so-and-so, I want so-and-so to speak for me, then doing bedside rounding with that other person in the room and discussing all of it right there, especially if that person wants to know a lot of information, is a huge time saver. You probably saved your team 45 minutes or an hour later in the day of coming back in, and then not only having that discussion, but having to have it again when you come back the next morning. So be aware of the family environment. Of course, sometimes it can actually be not so helpful. I've already touched on preparing your learners for the interaction. Definitely respecting the patient's human needs. This is a great thing that you can do with bedside rounds. If it's pretty obvious the patient is cold or the patient needs to be changed, you're sitting right there in the room, the team can help turn the patient, or you can call the tech right there, just push the button, hey, we're in the patient's room, do you mind coming in here, and we can help get the patient changed. And then it's important to be flexible. Things are going to come up. Unexpected things are going to happen we're humans, we're not robots, so different unexpected things will arise as you're talking things out in the room. It's important just to be flexible and to know, ultimately we can talk this all out. We don't, just because yeah, we are all humans. This person who is the patient right here in front of me, that could be one of us one day. We would certainly want respect to be shown to our opinions on any of the discussions, so this is a great time to talk it all out, talk their care out, and have them buy into it. And then last, we talked about this earlier, just about setting expectations. I really think with the bedside rounding, this is an important thing to really reflect on what has worked and what hasn't. So one of the big things that I mentioned earlier that has come up often is this situation where something has changed about the patient's status since work rounds happened, or the resident rounded with the team earlier that morning. And there's uncertainty because the student is presenting about what should be done, and the student gets to the plan portion and doesn't know what to do yet. So it became obvious that needed to become part of expectations, and I left it out from before. So be thinking about things like that come up, and then think about yourself and how you handled bedside rounds, where you might have spent too much time, the patients you should have seen but didn't, the patients you saw but shouldn't have seen. Geography of the building is often very important. Did we spend a whole lot of time getting all the way over to that other building, where the 5th floor of that other building where our one patient was over there and just needed one little thing, and we spent 20 minutes walking over there and back, and we lost out on the opportunity to see 2 or 3 other patients? So reflecting on those are very important. And I'll just say this at the end, there have been some instances at our institution where we had somebody else round with us. This is incredibly valuable. Asking somebody else to join you on rounds and give feedback, it's just a totally different thing when you're being viewed kind of as the primary educator. It is really impossible to gauge everything that's going on because you're trying to listen and take in a lot of information at once. So having somebody who can be like a fly on the wall one day can be very valuable when you can get feedback. All right, so any questions? We got about a minute or so, and we'll have some time at the end for questions as well. I'll just say this: if you don't participate in bedside rounding already, if you've never done it before, and you're a resident or a fellow, I think it's a great thing to suggest that you try. I think it's okay to make that suggestion. Hey, do you mind if we just talk about the patient while we're in the room? If that's even acceptable, of course, to do in clinic. And if you're an attending, I think it's a great thing just to give it a shot. It doesn't have to be wholesale change right at the start, but do it with 1 or 2 patients. Get comfortable with it, and I think you'll find that it's really rewarding and an efficient way to teach and evaluate.